I'm here because the part of the ambition obviously is to reduce gram-negative bloodstream infections by 50% by 2021. And Ruth May, who's the executive nurse of NHS Improvement, has been given the lead on that to deliver that across England. So I thought, if we just start by a quick poll of the room, do you think we can achieve this ambition of reducing gram-negative bloodstream infections by 50%, the healthcare-associated infections, by 2021? So if you put your hands up if you think we can. It's not many hands, is it? Probably not even a quarter of the room. So we've got a bit of convincing to do then, and we need to get on with some improvement work. And I think that's an important point to make, that NHS Improvement's role in this is about supporting improvement. It's not coming in as the regulator as such. It's about how do we support the systems out there to deliver improvement for our patients and to reduce harm. This has been spoken about realistically. We've all worked in infection prevention and control. We know what it's like to have targets. We had the C. diff ambitions, we had the MRSA ambitions, targets they were, weren't they? And if I'd have sat in the room at the beginning of that journey, not many people would have been convinced we could deliver those either. So I think we can, I believe we can have a big impact. And as we've already spoken about, the E-Coli rates are going up, and interestingly, so are the MSSA rates going up. And we've been collecting that data for many years, and yet we're now starting to do something quite a while. We started mandatory collection of E-Coli in 2011, and now we're starting to say that we should be doing something to improve that. But there's many people out there, many organisations who have already started on the journey, so we do need to learn from them. I'd move on from that. This is the same data that we've been talking about. But there is an important message here that it is healthcare-associated infections, not all of gram-negatives. And for the baseline data, we're using the three main organisms. So we're using Pseudomonas, Klebsiella, and E. coli as the baseline for our reductions. The guidance has been published on NHS Improvement's website. I don't know if you've all been aware, there is an improvement hub there, and that was published last week, and we did send out links to the system, but I'm not quite sure about our communication, how does it reach the system, but we have been sending to DIPSIs as well, so you should be receiving things through a range of routes. So the key here is that there's not an exhaustive list about what healthcare-associated infections are, but what we don't want to get bogged down in, well, I don't think we should be, is about, is it your infection, acute trust, or is it your infection, CCG? These are people, they are patients who've come to harm. So we need to work together to see how we can change the outcomes for our patients. So we will be looking at, have the patients got an indwelling device? They might have a line in. Urinary catheters are going to be key. Have they had it manipulated? What have we done with it? Invasive procedures such as, have you been in and you had an ERCP? Have you had whatever done? Have you had your cholecystectomy, which I had done? Leading this programme was worrying me at the beginning of the year, but it all went very well and I'm absolutely fine. Invasive procedures, neutropenia, antimicrobial therapy in the previous 28 days, and a hospital admission in the previous 28 days. So that's some guidance, but this is for us to be working through to see how we can intervene to prevent infections. And I think that's really important. If we can prevent infections, we can prevent the use of antibiotics, and also we can obviously prevent people going on to become septic and getting sepsis. So our initial focus in the programme, so I started in January in NHSI and was asked to just lead the programme nationally. We are going to be focusing on E. coli because that links across nicely with the quality premium. So we've got that data, it's been mandated, we know an awful lot about E. coli, so we can start to focus some interventions. But it's really important that this is a health economy approach. Acute providers on their own are not going to just be the answer to this problem. We've got to change the way we think and the way we work, and we've got to move out from the acute provider to do it across the system. Now, I've had the privilege to go across and meet many different systems in the country so far, and people are doing it in very different ways, and we're not centrally saying this is what you must do. It's up to you to think, how could we deliver improvement? Some people are using STP footprints, some people are using existing improvement networks that they may have, Some are targeting groups that they've already got based around their CCGs. So there's not one size won't fit all, and what perhaps we do in London won't be the same as what we do in Cumbria or in the Isle of Wight. So we do need to think about how we approach that. And we need to work together, and we keep needing to stress that. It's not the same as C. diff and MRSA, just hitting the acute provider. We must think about how can we look at the patient's journey and how can we prevent that infection. We won't go into the quality premium realistically, but year one of our ambition is to reduce E-Coli by the 10%. So that'd be our measure of the end of year one for success. And for me, it's even more complicated because we've obviously got healthcare, but we've got a lot of people who are not in our systems, in the NHS, if you like. So how do we reach across into health and social care? How do we work with our local authorities, our local directors of public health, and the whole remit of people out there that we can use to get together to improve outcomes? This has already been spoken about, so if you're an area and you haven't started to look at your patients' cases, your data, the top clue is you might just want to start at looking at urinary tract systems until you've actually revised the way you're going to deal with that locally. So it's the easy point for beginning with, I believe. But for me, the benefits, there clearly is an issue about a target and ambition, but this is about patient safety. If we can reduce infections, we can improve mortality outcomes, we can reduce lengths of stay, and we can also get our AMR agenda correct as well. And it's the cost. There is a cost, there's a financial cost, but it's about that human cost as well, and we can't look at those things in isolation, and Ron's already spoken about that far better than I could. If I was to ask you in the room, how many of you work for an acute provider? Most of the room. Community provider? Very few. CCG? General practice? Nobody? From health and social care, so nursing home, residential home, one person, yeah. So Public Health England, sort of, yeah, quite a lot. So there's a mix, but predominantly it is acute providers who are in the room, isn't it? So I think there's an important message about how do we get together and how do we join across. When we've done our work, our scoping work, with lots of people from across the country, people have said we don't want to be told what to do by Wellington House, NHS Improvement, Department of Health. We know how to do it, we want to do this ourselves. And yet, when we go away from that, we constantly ask, what can we do, where do we start? So I think there are some things we can do to improve it. But for me, it's you've got to, wherever you are, wherever you work, you need to see how your system is going to work together to deliver the improvement. So how are you going to get together with everybody in the room? I didn't ask anybody in the room. Was anybody from the Ambulance Trust here? Yeah, they're right at the back of the room. So it's about the groups, all the groups I've been to, the Ambulance Trust have not been in the room. That's only why I asked that question. So it's important that we do think about our colleagues in the Ambulance Trust. So we do need to understand also that this is data that we're getting, but it's patients who have been affected by infection. So I get wound up, no, I probably do get wound up actually, about people talking about this is the data, who's going to do the data entry, but we've got patients who've been harmed, and it's about how do we use those case studies to get information to do improvements. That's really, really important. How many of you use PHE's fingertips? A few people. So there's a lot of data there that you can go on there and pull out, see what you look like, what your health economy looks like, what your CCG looks like, what prescribing look like. There's an awful lot of information that's readily available. So a good place to start if you haven't got any local data. Then, as part of the quality premium, the CCGs, the payment will be that they are reviewing these cases, and can we look at where what's the source of infection, how did it occur? So that is a challenge for some organisations I know, and people are wondering how they might be able to deliver that. But equally, as Abid said, there's lots of other people who are already involved with those patients, and we need to see how we work together to collect the information about the patients and their infection sources. Also, very important that we need some kind of plan. There's no good at everybody going off into a room. I was in one area, I won't say where, the other day. We were working with 3 CCGs, and then we mapped out currently how many meetings there were. It was not only CCGs, there was lots of other partners in the room, and they were actually having 24 different meetings around either IPC and AMR. So imagine the time that could be released if we actually looked at having a far more joined up approach, and then perhaps have some working groups that then just looked at the management of continence or the management of hydration or the management of sepsis. So I think there is an important thing about saying where are we meeting already, how are we meeting, and who are we meeting with, and is it actually we just need to invite 4 more people to our meeting to make sure that we've got cross-system approaches there. But there's lots of data out there, so do use the data to help inform your decision making. I'll whiz through that because you can't read it very well. NHSI, we have published on the Improvement Hub a resource to help you reduce gram-negative bloodstream infections. Now, it is not an amazing resource. It's nothing fantastic and new. It's pulling together resources that are already there. But what we want to do as the plan, as the programme, as the years progress, is how can we get together to add to this resource, put useful things on there that we can then share, because we don't want everybody in England going off devising a catheter passport. If there's a really good one, if we think of Scotland, they issue their guidance centrally, nationally. They have one catheter management plan. We don't all have to go make our own. So if we've got examples of good practice that we can share, we would like to put them on the Improvement Hub so you don't all have to go off and reinvent the wheel, and we can share what we're achieving. Looking at case studies, and we know pieces of work that have improved outcomes. So it is a bit of a naff resource, but it will get better as we develop it and as we get it more interactive and as a web base. We've tested that resource with, well, it says 4 CCGs, but it was actually 4 meetings with many CCGs to see how we can make that better. It's got a range of information in there, and I'm not going to go through all of that, but it's pointing us to stuff that we know we should be doing. And yet, I think, perhaps, if I'm honest, that infection prevention and control, if we're looking at acute providers, if you've been doing all right with 2 top targets, your MRSA and your C. diff, perhaps it's not as high on the agenda as it's been before, so that's infection prevention and control. There is still variation, so we do need to make sure that it is kept up there as a priority patient safety issue. So next steps for NHS improvement, this is really, which we need to say is that we cannot deliver this ambition. The only people who can deliver it are the people like yourselves who are working with the patient and the public to prevent infections in the first place would be the very best start. And then if we've got an infection, that we manage it correctly and we prevent people going on from getting sepsis. We would like to share things that you have, success stories, or even if it's something that you did and it didn't work, it's really helpful to tell people that that wasn't a success and you invested greatly in it, but there was not the benefit. So we do need to learn from that as well. So please contact us in NHS Improvement, me, if you would like to be part of that. And what the feedback we got was that when the MRSA and C. diff teams, the Department of Health Improvement teams, are out and about visiting us, what people did like was the performance improvement, the PIN events. There were events where people could share work that they were doing with their colleagues. So we've started with setting up some PIN events as a starter for 10, if you like. Those are the dates there. So you probably would be coming to Manchester, I'm guessing, if you were here. So I would like any of you would like to come and speak at that PIN event to contact me or grab me, and we can arrange for that to happen. And then we would test that out and see how it works. So I would also value feedback about, is this the best way we can reach as many people, or are there different ways that you think would work? We need to listen to you and learn from you, and we will support you as much as we can. We are recruiting to some posts in NHSI, but it isn't about us in NHSI delivering it, it's about you guys out there delivering it. So that's probably where I will stop. But please do contact me if you would like to help, you'd like to share your work, and we can get on and begin to improve things for our patients. Thank you.